organizers for giving me this opportunity. And I always enjoy speaking after Dr. Rewari and Dr. Kumar, because Kumar and Rewari present the same data, but Kumar had so many adjectives: tremendous, terrific, excellent, and remarkable, etc. So let's have a reality check. It's uh, for getting to zero. We were saying that there has to be 90% reduction in new HIV infections, 90% reduction in stigma and discrimination, 90% reduction in HIV-related deaths. And for getting to zero, we are now all, talk of the town is getting to 90, 90% diagnosed, 90% on treatment, and 90% virologically suppressed. HIV care continuum is largely spoken of in terms of patients who are HIV infected. And it is like test HIV positive, engage them in care, pre-ART, then retain in counsel and put them on ART and keep them virologically suppressed. However, there has to be another continuum which is of prevention and care, because we have to keep all the negatives also negative. And that will be achieved to a certain extent by treating all, but of course there will have to be other efforts for prevention also. And there will have to be other modalities used, and we'll have to integrate both HIV infected and HIV uninfected people into biomedical, behavioral, and structural interventions. A broader perspective of HIV care continuum, therefore, is like HIV testing. Those who are negative, keep them negative, put them back into the HIV care continuum. Then largely we are always talking of people on ART, and they should be adherent to ART and continued in care, but there have to be a lot of linkages also, and which need to be, actually that care continuum also has to be maintained when we have to have something like 2.1 million people on ART. If we test all and treat all, there would be 2.1 million people, and there will have to be a PMTCT care of co-infections and comorbidities, because the comorbidities, even if they are less if we start early, still there are going to be a lot of comorbidities, as well as TB care. What we are expecting is that when we move, whenever, maybe 3 years down the line or 4 years down the line, or maybe 2 years down the line, I don't know. Kumar is always asking Dr. Rewari to cut short the lag period, and so we'll expect someday that not eligible for ART will go. So anybody who is diagnosed would go on treatment, and we'll have that. But what happens in reality? Now this is the data from United States. 87% diagnosed, 39% received care, 36% prescribed ART, and only 30% of that on virological suppression. UNAIDS targets 90-90-90. There are 36.9 million people in the world, probably. So at 90%, there will have to be 33.2 million on ART diagnosed, 29.5 million on ART at least, and 26.9 million virologically suppressed. Target one is, yes, we'll have to have 90% diagnosed on ART and suppressed. But what happens actually? What is happening is that there is a 53% drop in the breakpoint 1, there is another 41% drop in breakpoint 2, and another 32% at breakpoint 3. So there is a distance between the cup and the lip. There are 90% diagnosed. We know that a significant proportion of adults in most parts of the globe with advanced HIV disease, we know that even what we are seeing is that majority of the diagnosis is even increased. It is around 200 CD4 count, 230 CD4 count. So yes, Kumar says that we will have a national, 5-year national screening of all people, maybe all 110 crore people maybe, every 5 years, and then diagnose all and put them on treatment. But there is a lot of investment needed to be done in that. 90% on ART, less than half of PLHIV from sub-Saharan Africa not yet eligible for ART are retained in pre-ART care, and only 2/3 are initiated on ART. Virologically suppression, 71% PLHIV from low and middle income countries are initiated on ART, show virological suppression. And just now Dr. Ghate also showed that people put on ART, at the end of 1 year, so many people were failing on the regimen. So maintaining the suppression is also not a very easy thing to do. What is the Indian scenario? And there are some data. Majority present to care with advanced disease, HIV diagnosis to care, there is a significant delay and there are losses on the way. These are the systematic reviews and the data from that. 80% of those diagnosed with HIV reached ART centers, Shastri et al. Among those reached, 25% registered after 3 months of diagnosis, including 12% reaching more than after a year, Sarna et al. Most of those who did not enter into care within a year remained lost to follow-up or died. So it's not just diagnosing, but putting them into care is also very difficult. Attrition during pre-ART and ART era, public sector, Ghate madam's paper, 2% deaths and 11% lost to follow-up during pre-ART care. 13% deaths and 16% lost to follow-up at the end of 2 years, Bachani's paper. Private sector, our paper, there is data, 65% of non-eligible retained in pre-ART care, 67% eligible initiated ART within 3 months, and 30% initiated at ART died or lost to follow-up. This is our paper. Timely uptake of subsequent CD4 was only 58% among eligible patients and 46% among not eligible. So almost 50% of the people, even if they are eligible or not eligible, as per our criteria, hardly do their CD4 count in 3 months. This is our data. Late diagnosis, delayed linkage, as I just now said, lower uptake of follow-up, CD4 count among those with delayed linkage and higher CD4 count. So those who get linked late also remain defaulting or getting linked to the care very rarely. As regards TB, what happens? We just published a paper in International Journal of Tuberculosis, 1st of October. There is a significant anti-tubercular default, 4 to 30% and mortality rates observed among HIV TB co-infected patients. There are other data also. Higher default in private sector and among those not on ART. So there, when we actually look at everybody is diagnosed and put on treatment, there is going to be a substantial proportion of them going to the private sector also. It's not that 100% of the people would be in the government sector. There is a higher default in private sector and among those not on ART, so these linkages will have to be looked at. The issue with linkages are 2 ways. Out of 923 patients diagnosed with TB, 102 were lost to follow-up before initiating anti-tuberculosis treatment. Forget about antiretroviral treatment. Even the anti-tubercular treatment could not be started in them. 18 to 56% of ARV-naive TB patients cannot be started on ART. What happens to them is not known. Let's look at PPTCT. Retention in PPTCT cascade of care. Our paper, uptake of HIV testing was 86%, and just now Dr. Rewari said that we have 28 or 29 million pregnancies annually, and hardly about 45%, maybe around 40% are being tested, and so we will not be able to reach all unless we screen all of them. Uptake of ART was 46%. Linkages from PPTCT to HIV care. Since their exit from PPTCT, we did a retrospective study and then followed the women who had exited PPTCT program, but that was at the time when the treatment was not continued lifelong. The treatment was stopped at the after pregnancy and delivery when CD4 count was good. But what we found was only 62% were consistently in treatment. So there are several risk factors and barriers to linkages and retention in HIV care, and we have to remember that. It's not just a test and treat, go everywhere and test someone and put on treatment. It's not going to be that easy. There are several demographic factors such as male sex, younger age, low education, unskilled laborers, migration. There are psychosocial issues like stigma and discrimination, fear of disclosure, partner family support, fear of drug toxicities. There are issues which are medical. For example, perceived good health. You are having good health, you are not sick, your CD4 count is good, would you like to be on treatment for a very long time? There could be problems when there are low CD4 counts, when you are more and more sick and you may not be able to take so many medicines. And ART naive status. So you may have experienced ART before, you have left and you are coming on treatment again, or you are ARV naive is also important. There are economic reasons, food shortages, unable to take time off week, cost of transport. These are all the factors which have been collected from several systematic reviews. And health system related issues like long distances, long clinic waiting times, shortage of health workers, need of visiting multiple times, frequent visits due to drug shortages, and all this Dr. Rewari was also addressing that these are going to be taken care of. So there are challenges galore, but there are possible solutions to these also. For example, streamlining services to minimize patient visits, and we are already talking of quarterly or 6 monthly visits. At our center, we are those who are virologically suppressed and have good CD4 counts are coming now only twice a year, and once a year virological monitoring, strengthening education support during pre-ART phase, Same day CD4 testing is excellent because majority of our patients come in the morning, take their CD4 counts and go away in the evening. Of course, virological monitoring cannot be done on the same day. Rapid ART initiation, there is quite a bit of loss to follow up. So when we have test and treat, maybe just like we do in PPT-CT, that a woman who is diagnosed with HIV, we don't wait for her CD4 counts to come, we start her on treatment. So similar thing, starting ART at the same visit, there has to be a lot of peer support to all these people. Convenient clinic timings, not fixed schedules, etc. And we have to look at some other technologies like mobile health or something which would keep giving the patients reminders for treatment and educating the people. We did a randomized control study of sending mobile messages to people for adherence and treatment. Facilitating links to RNTCP monitoring center mechanisms through intermediary organizations and involvement of private and public partnerships. So this is the photograph from somewhere. Simplify the way I get ARVs. I'm tired of walking, and there is a lot of time wasted by people in getting to ART centers, even if diagnosed. And the person is walking for his ART, and we have to walk on our path of taking treatment to all. Thank you.
Thank you, Dr.